I'm David Armstrong and
Manish Bharara.
And I'm a professor of surgery at the University of Arizona and also director of the Southern Arizona Limb Salvage Alliance, or SALSA.
And I'm the research assistant professor in the Department of Surgery, and I serve as the director of operations for our SALSA service.
Around the world now, diabetes has reached epidemic proportions. Some of our colleagues in the World Health Organization suggest that 400 million people now may have the disease, and this is only getting more common now. It is truly an epidemic. One of the most common reasons, if not the most common reason, that folks with diabetes will end up in hospital is not for a heart attack or a stroke or high blood pressure or high blood sugar. Remarkably, it's for a foot problem. In fact, foot wounds occur every 3.5 seconds in the United States and in every fraction of a second around the world. And it usually happens because people lose the gift of pain. They develop neuropathy. When that happens, they wear a hole in their foot, just as they would wear a hole in a sock or a shoe.
We've been working with a technique called thermometry, which is essentially temperature mapping of anatomical sites. And in this case, for the feet, we use a variety of different temperature sensors to look at temperature distribution on the feet and relate that information to identify hotspots or areas of inflammation, which is hallmark sign for underlying ulcer or a wound. And using this technique in a serial fashion over time, we can develop patterns which essentially help us predict these wounds in this population for diabetics. Over the last couple of years, we've been working with this technique and developing a device that combines imaging, and this is not just temperature imaging but also visual imaging.
These things are like, if you will, a glucose meter for someone with diabetes. So someone might check their blood sugar and dose their insulin. And so too might you be able to check your skin temperature through techniques like this and dose your activity if you're at home. So this serves like that. But if you're in clinic, the doctor, he or she, or the nurse, he or she, can check inflammation to help dose specific therapies.
Over the years, we've collaborated with other academic groups and industries to develop our research into products, and it's really exciting times for us because we are seeing those research results being converted to products now, and not just you know, it's more than one, and which is very exciting because we have products that are going to be developed and put into patient homes. We have products that are under development through funding initiatives from TLA that are going to be used in hospitals and clinics. So it's exciting times for us, and I think over the next couple of years we're definitely going to see results.
The elegant aspect of the works that we've joined forces to try to improve on is what people might call signal processing, to be able to identify something that's really clinically meaningful into something that can be done really quickly and that can identify a problem before it ever happens. And that is really what's dynamic now, and it's really exciting. We may be able to reduce hospitalizations and rehospitalizations because those are amongst the most common reasons for people with diabetes to be hospitalized, right, Manish?
Absolutely. We are motivated every day in the clinic when we work with our patients and see the cost of the problem, not just in terms of financial cost, but also how it affects the quality of life for these patients. That's why our group is unique in a lot of ways, because we just don't treat our patients. We actually look beyond that. We want to prevent problems, and that's what keeps us motivated.
You hear bench to bedside, but we don't think it's bench to bedside. We think it's bedside to bench to bedside. And all of these ideas should start with some degree of practicality from the patient, patient-centered, and from the doctor and nurse and other folks there. They can then be translated over to the bench, but then rapidly brought back to the bedside. We think very strongly that if we can identify these problems earlier on, that we can prevent upwards of 85 to 90% of amputations in people with diabetes.
Our group is sort of unique in ways because we work with clinicians, basic science scientists, engineers across the domain, from mechanical engineering to biomedical engineers, and we've shown it to be really productive over the years.